So commissioners, bring the meeting to order. Commissioners, I just make you aware of a business item here. We no longer have the little microphones in front of us, that you recall. There are speakers in the room, and they're on all the time. So everything you're saying is being recorded, at least while you're in this room. I would ask people to whisper if you're not actively speaking. Speak to the person next to you. Or try and refrain from speaking. Personally, I'm not very good at that.
Can we rescind what we've already said?
For the record, sure.
Like recalling an email, it always works.
Notice we have some a relative paucity, like zero certificate of need actions today. So as a result, I see a lot of empty seats in the room. I consider decreasing the price of tickets for these particular days. Now I will entertain a motion to approve the minutes of the May 16, 2019 public meeting of the Commission. Commissioners have had a chance to review the minutes and ask questions about them. Any discussion? Seeing none, all in favor?
Aye.
Aye. Any opposed? Minutes are passed. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Seeing none right now, do the executive director or any of the center directors have additional updates? Okay.
Thank you, Mr. Chairman. First off, I wanted to let everyone know that I have appointed Ken Yates Trotman as the new director for the Center for Analysis and Information Systems. Ken has served as in the acting capacity for several months, and during that period, he's demonstrated steadiness and intelligence that warrants his promotion. His elevation is supported by the staff in that center, and it was only made after we went through a recruitment process in which the evaluation committee judged him the best qualified for the job. So congratulations, Ken, on the promotion. We appreciate your work. So the second, today you'll notice that we have bigger, not only do we have a very sensitive microphone, but we also have bigger screens, and that was due to the work of our IT staff who largely supports this, even though HSCRC uses it. This was all put together in 2 days last week to support HSCRC's arguably their most important meeting of the year, the one in which the annual update is agreed to. So it was very important this meeting be back in shape, and Levon and his team with the contractor really worked hard to get it together. The issue on the microphones notwithstanding, everyone can now hear in the back, which has been a problem and a complaint for a few years. Levon's back there, so he can let him know. So
based on the look on Levon's face, I'm not sure it's working.
he is not his head.
Exactly.
Some tuning may be necessary, but we're moving in the right direction. I want to just, I was told I used 30 minutes last time. I'm going to use about 5 this time and just say briefly what I wanted to tell everyone, that we established 5 strategic priorities last December. We're moving forward on all of those priorities. I'll be sending out a short memo describing our progress on educating and informing the healthcare community on making MHCC a trusted source for healthcare information, expanding the use of telehealth, modernizing CON, and working to expand practitioners' engagement with value-based programs. The other little note I would say in terms of elevation and elevating telehealth, the Commission has been contacted by the State Department, who has a visiting delegation coming to Maryland, to ask that Maryland Healthcare Commission provide some input to the Saudi delegation, who is very interested in use of home-based telehealth. We'll find out if they mean the same thing as we do, but we're excited that we're going to have a presentation with that delegation in the middle of July. I guess that does mean we're somewhat elevating it or getting some attention. But I'll share with you a short memo on our progress. I have nothing else to say.
Thank you, Ben. David?
So good afternoon, Mr. Chairman, Commissioners. I have one addition to the update regarding telehealth. So it was an interesting segue there. As you recall, during the 2018 legislative session, the Senate Finance Committee expressed concern about the slow pace in the development of telehealth in schools. The committee requested that MHCC convene a work group to identify deficiencies in existing policies related to school-based telehealth programs and develop an approach for improving these policies. The work group continues to deliberate and staff plans to present final recommendations to you later this summer. One of the key working themes focuses on increasing awareness about the value of telehealth in schools. Staff is collaborating with the Maryland Association of School Health Nurses to develop a 3-part webinar series aimed at increasing education, which in collaboration with the Maryland Nurses Association, we plan to implement the series in September of this year. Focus areas for the webinar include telehealth use in school health services, expanding access using telehealth in school health services, and strategies for telehealth program success. The medical director of the Healthy Schools program in North Carolina, the lead nurse practitioner for the school-based telehealth program at the Medical University of South Carolina, and the nurse practitioner for the telemedicine school-based wellness center at 6 Howard County Public Schools will be featured presenters in these sessions. The event is notable as it represents the first step in building awareness among school health nurses and how telehealth can be used to increase student access to health care and improve academic and health outcomes. Leading the development of this initiative on staff is Justine Springer, and Nikki Majewski and Eva Lenore have been key contributors to the work group recommendation development process. Mr. Chairman, Commissioners, that concludes my addition to the update. Happy to answer any questions.
Questions for David? Hearing none. Teresa?
I'd like to provide a brief update on an activity that's underway in the Quality Center. Although our primary work surrounds maintaining and enhancing our quality measures, data collection and reporting infrastructure to support the Quality Reports consumer website, we're always looking for ways to facilitate quality improvement by working and collaborating with the industry. A couple of examples will be the progress we made with HAI reduction. We worked with the Maryland Hospital Association several years ago in reducing CLABSIs in ICUs. You may recall just a couple of years ago, we started an initiative with the Leapfrog group to ensure that Maryland hospitals would participate in that grading system. So they're now participating in that. Last year, the Maryland Cardiac Surgery Quality Initiative, MCSQI, approached us. This is a consortium of the state's cardiac surgery practices focused on improving quality of cardiac surgery in Maryland. The group works closely with Paul Parker and Eileen Fleck of the Health Facilities Planning and Development Center on Certificate of Ongoing Performance Program issues. The MCSQI reached out last year for guidance on how to access and work with the statewide hospital inpatient discharge database, which is collected by HSCRC and used by MHCC as well. We worked with them and came up with a process where we would link hospital charges to the clinical data that the MCSQI group has, the STS data. We were successful at doing that linkage, and they've come back to us and asked if we could work with them in linking data so they can look at reducing readmissions. So we thought this would be a great opportunity to collaborate with not only the NCSQI, but also with HSCRC, because they're also focused on reducing readmissions. So we're trying to develop a more collaboration between the two entities so that we can either provide the linkage for them again and then deal with data use agreement issues, the parameters of whatever work is done, try to connect the NCSQI through with the HSCRC subgroup on readmissions so that they can also be plugged into what's going on. So it's just to let you know of a collaboration. We'll keep you posted. It may take us some time to work through these issues, but we will definitely come back and maybe have the group come and present briefly as well.
Any other questions for commissioners? Hearing none. Before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should move to the MHCC conference room. Staff will let you know as soon as the commission has completed action on that particular agenda item. Yeah, thank you. Just to take attendance of those on the phone, we can see who's here in person.
Margaret Hammersley is on the phone.
Commissioner Hammersley and
Commissioner Marcia Boyle is on the phone.
Excellent. Anybody else? No. Very good. On to agenda item number 3, adoption of state health plan chapter for nursing homes and state health plan chapter for special hospital chronic services. The next item on today's agenda is consideration of adoption of state health plan chapters as final regulations. Action A, COMAR 102420, state health plan for facilities and services, comprehensive care facility services, final action. At its February 2019 meeting, the Commission adopted proposed regulations under COMAR 102420, which would repeal and replace the nursing home portion of COMAR 102408, a chapter of regulations that currently address both nursing home or comprehensive care facility services and chronic hospital services. Commission staff is requesting adoption of COMAR 102420 as final regulations today. This will create a chapter of the state health plan that will be limited in use to the review of certificate of need applications involving nursing home projects. Staff is also requesting, as a corollary to adoption of COMAR 102420, that the Commission adopt a new version of COMAR 102408, which going forward will only address chronic hospital services. The chronic hospital standards themselves are not being updated at this time. A formal comment period on the proposed regulations ended in mid-May. 3 comments were received. They addressed the nursing home regulations in COMAR 102420. Linda Cole, Chief for Long-Term Policy and Planning, will review the comments and outline the staff's response and recommendations. The Commission will consider adoption of COMAR 102420 and COMAR 102408 as separate actions.
Good afternoon, Mr. Chairman, Commissioners. Before I begin, I would like to thank the staff of the Center for the Quality Measurement and Reporting, specifically Julie Debbie and Stacy House, for providing the data analysis needed for the CMS star ratings. What I would like to do today is briefly review the adoption process, discuss the comments received during the latest public comment period, present the staff's analysis, response, and recommendations, as well as next steps. As you know, this development and promulgation process has been going on for a while. Prior to its release, staff developed the chapter with the help of a work group composed of representatives recommended by the Health Facilities Association of Maryland, Lifespan, Medicaid, the Office of Healthcare Quality, and a consumer representative. During the past year, the Commission has twice adopted the proposed chapters. The chapter is both COMAR 102420, Comprehensive Care Facility Services, and 102408, Chronic Hospital Services, were released for informal public comment on June 6th, with comments due by July 9th. In response to requests from the industry, this was extended to July 13th. No comments were submitted on Comar 102408 chronic hospitals during any of the comment periods. At its October 16, 2018 meeting, the Commission voted to adopt both Comar 102420 and 102408 as proposed permanent regulations. The formal comment period was held from December 7th, 2018 to January 7th, 2019. Again, comments were submitted only on 102420. Following discussion, the Commission voted at its February meeting to adopt staff's recommendation and remove subsection .04B3, dealing with the docketing exception risk sharing between hospitals and nursing homes. Because this was a substantive change, the chapter was reproposed and again sent for comment from April 12th through May 13th, which brings us to where we are today. The only major change in this version of the chapter from the previous version is removal of the docketing exceptions of the risk-sharing arrangements between nursing homes and hospitals. In both the October and February meetings, commissioners considered the comments and staff recommendations and voted to adopt the proposed CCF chapter without any additional changes. So the issues raised during the comment period that will be discussed today have been presented to you before and voted on previously. During the most recent comment period, comments were received from Health Facilities Association of Maryland, or HFAM, Lifespan Network, and Lorient Health Systems. We appreciate their comments and thank them for taking the time to participate in the process. The issues raised focus on the docketing rule exceptions, and these can be found in the proposed chapter, the first one on page 8, the second on page 9. First docketing exception, .04B1 states, the Commission may docket an application proposing the addition of comprehensive care facility bed capacity in a jurisdiction without identified need for additional beds. If more than 50% of the comprehensive care facilities in the jurisdiction had an average overall CMS star rating of less than 3 stars in CMS most recent 5 quarterly refreshes, this will be referred to as the CMS star rating. The second docketing exception states, the Commission may docket an application by an existing freestanding comprehensive care facility with fewer than 100 beds that proposes a replacement facility with appropriate expansion of bed capacity in a jurisdiction without identified need for beds. If the applicant demonstrates A, replacement of its physical plant is warranted given the age and condition, and B, the additional capacity is needed to make the replacement facility feasible and viable. This will be referred to as the small facility replacement. The quality standard, .05AE, requires an applicant to demonstrate that at least 70% of all the CCFs owned or operated by the corporate chain had an overall average star rating 3 or more stars in the 5 most recent quarterly refreshes. This slide indicates the major objections raised to the first docketing exception related to the 5-star rating system. One is a general objection to any docketing exception. That is, despite the fact that no bed need is currently projected for any jurisdiction using the nursing home bed need methodology, commenters suggest that no additional beds should be added to the system at this time. Commenters mentioned Maryland's nursing home pay-for-performance system as another alternative. As we discussed previously, this is a Maryland-specific system and can be used only to assess performance of in-state facilities or Maryland applicants. It is also dependent on the Youth Testing Commission's Family Satisfaction Survey, which had not been updated until recently. And finally, as commenters indicate, the legislature directed funds to make pay-for-performance more patient outcome specific, so it also was undergoing change. Another issue raised is the perceived volatility of the CMS star rating system in light of recent changes made by CMS. Because of the correlation between the presence of an RN and the quality of care, CMS changed the permitted number of days without an on-site RN from 7 to 4. That means that a facility with no RN on site for 4 or more days receives an automatic downgrade to 1 star in the staffing domain. It should be noted that the overall rating can still be offset by other domains. There are other recent changes, such as lifting the temporary freeze on health inspection ratings, and these are all detailed in the analysis of comments which you received. Commenters also point out that if 50% of facilities are below average, that is 1 or 2 stars, that 50% are at or above average at 3, 4, or 5 stars. They feel that these facilities, 3 stars or higher, would be at a disadvantage. However, it should be noted that such facilities could apply to expand their capacity through the proposed exception. In the data presented in February, Allegheny County, Queen Anne County, and Washington County qualified for the docketing exception. Now, Allegheny, with 5 of 8 CCFs below 3 stars, and Washington, 7 of 10 CCFs below 3 stars, again qualify for the exception. Since Queen Anne's County contains only 1 nursing home, its change from 2 stars to 3 stars affects the entire jurisdiction. With respect to the perceived volatility, HVAM in its comments mentions the changes in the facility star ratings between March and April of this year due to changes in CMS rules. It should be noted that the quarterly refreshes are done in January and April. However, in comparing the 2 time periods, there is a lot of change in individual facility ratings. However, the issues identified by HVAM and others, shown at the top of this page, do not match the actual application of the docketing exception. If there are changes from 5-star, much above average, to 4-star, above average, or 3-star, average, it doesn't matter because we divide rankings into 3 stars or above and below 3 stars. Also, we do not use individual facility rankings. Instead, we use average ratings of all facilities across the jurisdiction. Further, in response to earlier comments during the informal comment period, we use 5 quarterly refreshes, which accounts for a 2-year period of data. All of these factors reduce any volatility measures that would appear in looking at individual facilities from 1 month to another. And as shown in the previous table, the bottom line is that only 2 jurisdictions in the state would qualify at this time. As mentioned previously, the perceived volatility does not match the actual application. This applies also to the quality standards. This has also been stable over time. There was a change in 1 CCF change between the January CMS refresh and April. There was very little change in the other 87% of the CCFs. To summarize staff's response on star ratings, using a longer time period minimizes volatility. Commission staff from the Quality Measurement and Reporting Center reported last month that the Maryland Experience and Care measures are highly correlated with the overall star rating. CMS Nursing Home Compare star rating system is national, validated, and standardized. It's used nationally for bundled payment by commercial payers, hospital networks, and lenders. Moving on to the second docketing exception for replacement of small, outdated facilities below 100 beds. There is again general opposition to adding any bed capacity. There are some recommendations to set a limit on the number of beds that can be added, and mention is made of the waiver bed rules, which are 10 beds or 10%, whichever is less. There are only 50 freestanding CCFs statewide that have fewer than 100 beds. And this is actually an overstatement because the exception rule is limited to facilities that can demonstrate the need for replacement based on the facility age and potentially unsafe infrastructure conditions. The bed addition is limited by the requirement to demonstrate financial feasibility and viability, which will vary by facility. This exception rule should not be confused with waiver beds. Such beds, 10 beds or 10%, are intended to allow for some institutional flexibility for operators of facilities who may need to make small changes to address staffing issues or reconfiguration of beds between private and semi-private routes. This requires that there be existing physical space in which to add beds. Adding 10 beds to an outdated and potentially unsafe facility does not address the larger infrastructure issue. And finally, facilitating the replacement of outdated physical plants and making facilities financially viable are important policy objectives that can be met with minimal impact on the overall CCM bed capacity. Based on the staff analysis presented, staff requests that the Commission adopt COMAR 102420, the CCF chapter, as final regulations to replace the Commission's current regulations regarding nursing homes contained in COMAR 102408. I will discuss staff recommendations regarding 102408 in the next matter on the agenda. If the Commission adopts 102420 as final regulations, it is anticipated they will be published in the July 5th Maryland Register with an effective date of July 15th. I'll be happy to answer any questions on that portion.
Before that, do I have a motion to adopt COMAR 102420, State Health Plan for Facilities and Services, Comprehensive Care Facility Services as final regulation? All right, discussion.
The only question I have is, we took out that provision dealing with the total cost of care and the risk sharing. If that were to come back in play in the next couple of years, how difficult is that going to be? Is it going to require a change in the whole plan, or is that just an addendum, or what do you suggest?
It would require a modification to the plan, which would have to go through the regulation process for comments.
The process route is reviewed, but the entire review of the regulations as is necessary, as occurs here, doesn't have to occur. We could just add that chapter back. Or not.
So whether that provision exists or not would not, for most facilities, preclude them from participating in a risk-sharing arrangement. And there is a risk-sharing framework today that HSCRC has developed that mirrors something that's available nationally called the Facility Care Improvement Program. What we had in the February draft would have allowed a facility to expand if that was the only way they could participate in a risk-sharing arrangement, which would be somewhat of a unique arrangement. It's my judgment that most nursing homes would be able to enter in this type of risk-sharing arrangement, or another one that's still in discussion stage without worry about expansion at all, because we do have excess capacity in most facilities.
So you're saying that hospitals can do that now with an existing nursing home provider that's available to do that?
Correct, and most of these are aimed at reducing or shortening bed stay nursing home. So
there's nothing about this regulation that allows them to enter into risk-sharing agreements. It simply said that if they were in those, they could use that as a docketing exception to vending capacity.
Thank you.
Commissioner Evans?
There has been some change, and I saw it around a facility. It didn't impact us, but it impacted some of my friends' facilities that operate in our area. They're very good facilities. I saw regarding the star rating. I just want to make a clarification there. Their star rating did drop pretty quick with the latest change in some of the CMS rules. So there is concern about that. There's a little bit of a valid concern about that. I wanted to make the rest of the commission aware of that change does have some impact. I know that we look back over 8 quarters now instead of just one period, but that process has changed. So and it causes a little bit more additional worry there. Question I had was with because I don't believe I ever asked it with the fewer than 100 bed rule on the second part of that. How do we determine the 100 bed method? How did we, as a commission, determine that number?
Because the facility has less than.
Yeah, less than 100 beds with the.
We have an inventory of their license capacity.
I think the question is why do we decide that? Why is that arbitrary number selected as?
Okay, Generally, there's a size that's considered financially feasible. Obviously, it varies by whether there are many smaller facilities that are part of the network that have assisted living or part of CCRC. So we specifically excluded CCRCs and hospital-based facilities and just took what was considered small facility size.
I mean, I see the theory, for like the size facility I operate with 66 beds. It is much more cost prohibitive. We have a newer facility, so it's not as much of a problem. But it is tougher for smaller facilities to expand, given the capital requirements for new construction. So it's not possible. I understand that question. Thank you.
Commissioner.
Looking at the docking exception for the fewer than 100-bed facility, it's worded that it is an application for an appropriate expansion of bed capacity. And I guess I was wondering is there a separate determination then that we're making this is an appropriate or inappropriate expansion in order to get to the docking exception? And if so, what are we determining would be an appropriate expansion to take advantage of that?
I think it was felt that and again, an applicant would have to come in. We don't know that we will get any applications for this, but they have to demonstrate that due to the condition and the age of the facility, it needs a replacement, and demonstrate the number of beds that would make it more financially viable. So if it's a 40-bed facility and it just can't function that way and doesn't have sufficient staffing, they would have to make a demonstration. And we don't feel that we can say if you had 10 beds or 12 beds, it will have to be demonstrated in that project as to what would make it viable based on the financials that they submit.
So you're sort of reading that as the number of beds they should be seeking to take advantage of the waiver should be tied to how many they need in order to become viable.
Yes, Member Chief Financial Member. Other questions? All in favor? We have a motion on the floor. Adopting 102420. Say aye.
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 Opposed? Motion carries.
Okay,
right.
on 102408.
102408 is next. Next, the commission will consider final adoption of a replacement for 102408, which going forward will only address chronic hospital services. The commission adopted a replacement 102408 as proposed regulations at its 2018 meeting. That hasn't changed. We haven't received any comments on it, correct?
Staff requests that the commission repeal existing Comar 102408, removing all regulations regarding nursing homes, contingent on Comar 102420 becoming effective as final regulations of the commission, and replace it with Comar 102408, State Health Plan for Facilities and Services, Special Hospital Chronic Services Chapter. This is comprised of replacement regulations that address chronic hospital services existing 102408. Staff recommends that the commission make one non-substantive change in subsection 0.04B8, which contains the definition of long-term care hospital, and the second sentence is deleted to make the definition consistent with Maryland law. This chapter is adopted as final regulations to be on the same time schedule as chapter 20.
We have a motion to adopt 102408 State Health Plan for Facilities and Services, Special Hospital Chronic Services as final regulations with the one non-substantive change recommended by staff. Motion. Second is discussion. No discussion on the floor. Any discussion from the phone? Hearing none. All in favor?
Aye.
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 Any opposed? It's unanimous passage. Thank you, Linda. Thank you to staff and commissioners for a lot of work in a long and arduous process regarding these two changes that has gone on now for over 6 months.
And I wanted to acknowledge the input from the industry. We understand that there's a lot of attention to these regulations. People put a lot of time into suggesting comments. I think the adjustment we made to the regulations, pulling them back in February and repromulgating them, does signify that we want to listen to the industry. I think they are a step forward, and we will continue to work with all organizations in the nursing home comprehensive care industry as we move forward, not only in this area, but in various value-based initiatives that are going to be important for us succeeding in the total cost of care.
All right, on to agenda item number 4, Maryland Primary Care Program Advisory Council nomination. Alana Sutherland, Program Manager and the Center for Health Information Technology and Innovative Care Delivery, will propose one additional nomination to the Maryland Primary Care Advisory Council. As a reminder, the Commission approved staff nominations at its April and May meetings. The Council serves in an advisory role to the Secretary of the Maryland Department of Health and provides input to the MDPCP Program Management Office. Ms. Sutherland, please proceed.
Thank you. Good afternoon. So, as the Chair mentioned, in April and last month, we presented nominees for the MDPCP Advisory Council. Just to quickly recap what that council is, the MDPCP as a program provides funding and support for primary care practices in Maryland to advance primary care by improving things like access to care and continuity, care management, coordination, and beneficiary and caregiver experience. This program is a key initiative under the total cost of care model, and the purpose of the council is to serve in a consultative role to the Secretary and to the Program Management Office. The MHTC will provide administrative support to the council, which are responsible for the activities you see outlined on this slide. And today we present a nomination for a Medicare beneficiary representative, Kevin Hayes. And this is his bio, and as you can see, he has extensive experience in analyzing Medicare physician payment services and as a healthcare planner. So staff recommends that the Commission approve the nomination of Dr. Kevin Hayes, and I'm happy to take any questions you may have.
Questions from Ms. Sutherland regarding Dr. Hayes? Seeing no questions.
Sure. So this is a Medicare beneficiary slot, and we have confirmed that Kevin is indeed a Medicare beneficiary. He offers the benefit of being heavily involved in Medicare policy for more than 20 years, and now receiving benefits from the program.
And can you just, how was he selected?
So we did go through several iterations with various people, contacted AARP, and last month I raised that concern that we hadn't gotten what we considered someone who would be knowledgeable and participatory, and Commissioner O'Grady suggested a couple names. I talked with Dr. Hayes. He lives in Prince George's County, which was, we want broad representation jurisdictions across the jurisdictions. So I thought he was a great choice. He confirmed that he was a Medicare beneficiary, and that was the basis for his recommendation.
Excellent. So, do I hear a motion to approve the nomination of Dr. Hayes? Discussion? Comments? All in favor?
Aye.
All
Aye.
opposed? Hearing no opposition, we have unanimous approval for Dr. Hayes to join. LaWanda Edwards, Program Director for Government and Public Affairs, will provide an update to the Commission on the implementation status of legislation in the 2019 legislative session, including legislation related to CON modernization, Chestertown, and the Trauma Fund, as well as a brief update on work groups and studies from the 2019 and 2018 legislative session. Luana?
Yes.
The floor is yours.
Okay, thank you. Good afternoon, Mr. Chair and all the commissioners and our guests. I just want to provide a quick update on the implementation of some of our key legislation from the past session. As you can see, we have our Certificate of Need legislation, House Bill 626, Senate Bill 649, Chestertown Assessment, Trauma Fund, EMS, new models, and the 2-year studies from the 2018 session. This Certificate of Need, House Bill 626 and Senate Bill 649, allows existing hospice and alcoholism and substance abuse intermediate care facilities to change bed capacity without a CON, of course, given a timely notice required to the Commission. The Commission has received requests from 2 alcohol and substance abuse treatment centers and 1 hospice center to increase bed capacity. One is the Maryland House Detox Center in Anne Arundel County. They plan to add 24 ICF beds. Recovery Centers of America, Bracebridge Hall in Cecil County plans to add 87 ICF beds. These beds already exist and provide residential level service. RCA will add ICF certification, allowing the beds to also be used for medically monitored intensive inpatient care. Carroll County Hospital plans to add 6 new beds, and the request can all be found on the Commission's website. The legislation also requires the Commission to review state health plan on acute psychiatric services for this year, and the work on this review is ongoing. The next, on these particular CONs, the legislation will go into effect on October 1st. The hospital capital expenditures and state health plan priorities. And the second one is non-hospital capital expenditures, changes in the definition of ambulatory surgical facility, and deemed approval for certain types of uncontested CON applications. The Commission is in the process now of letting hospitals and ambulatory services know about the change in the law as a result of these bills. And then I just want to mention earlier this year, our Center Director Paul Parker gave a presentation to the Commission outlining these priorities. And next, on Chestertown, the assessment. This year's legislation, 2019 legislative session, requires an assessment of services at the Chestertown Hospital. Senate Bill 1010, the conference report for House Bill 100, which accepted language from the Senate Budget Tax Committee report on House Bill 100, withholds $500,000 from MDH's budget pending complete of assessment. And then secondly, as the task orders, Chestertown and HSCRC are working on procurement, and proposals will be due in July. And staff has very limited discussions on this ongoing procurement. And next, we have the Trauma Fund. HB 607 and SB 901 makes Park Shark Trauma eligible to stand by and on-call costs from the Trauma Fund. The changes become effective July 1st, and the Commission is working with Park to obtain standby costs and to ensure Park understands existing standby payment processes and requirements. The Commission staff will devise a methodology for reimbursing Park standby costs by September. And the Commission plans to convene a work group to look at all the payment methodologies used in the Trauma Fund after July 1st. And next, the EMS new model. Last year, MIM and the Commission conducted a study of 3 models of EMS care: treat and release, alternative, destination, and mobile integrated health communities paramedicine. And the conclusion was more study was needed. This year, MIMS must submit a report that outlines the state's plan for reimbursing the 3 models of care. Commission staff will participate, but MIMS has the lead role. And this year, also, HTL Chair Pendergrass asked the commission to conduct actuarial study of models in private market insurance. And staff is currently working on this task. And lastly, also this year, CMS announced a EC3 national model for treat and release an alternative destination, allowing for potential Medicare payment to EMS and in some counties. And lastly, very quickly, I just want to give an update on the 2-year studies. The school-based telehealth is ongoing and the report is expected this fall. The health record and payment integration program is complete and has been submitted. The electronic prescription record system is nearly complete and a report expected this summer. And the infant mortality in African American and infants in rural area study is ongoing. We expect a report this fall. And that concludes my presentation. Is there any questions? Okay.
Just for information for me, as a new commission, can you just take a couple sentences as to the Chestertown assessment? How did that? What was the issue?
Okay.
Just a.
So there were a number. There's concern in the community in Chestertown that the Chestertown Hospital that services may be being reduced, and so we have now statutory requirements coming out of the last session to look at the services being offered now and compare them to the services offered in 2015. So that's we have to meet that requirement.
And report back.
And report back to the legislature. Yep. Any other questions?
Thank you very much.
Thank you.
Yes, good summary. Next up, agenda item number 6, privately insured report. Ken Yates Trotman, Director of the Center for Analysis and Information Systems, will present on the annual report on expenditures for privately insured services using the Maryland Medical Care Database, the MCDB. The privately insured report is an update on healthcare spending and uses among Maryland's privately insured under 65 population. Ken, the floor is yours.
The Maryland Healthcare Commission is required to report on expenditures, spending, healthcare spending, and utilization. Just reiterate that information, the source of the information is from the medical care database, and this information is submitted by private payers, which includes health insurance companies, TPAs, and PBMs. And the data that is used in this report is from 2015 to 2017. This year is the first time we have included the self-insured private plans, and previously we had only included full insured. This report studies on variation in spending by market segment, geography, age, and service category. As for takeaways, we see that healthcare spending in 2017 grew about the same rate across all markets as a year ago. And PMPM spending across all markets grew about 6% in 2017 compared to about 5% a year ago. Looking at the markets, we see that the individual market faster in 2017, which was up from about 16% in 2017 to about from an 11% increase in 2016. The small group market increased at about 6% in 2017 compared to a low increase a year ago. And lastly, looking at the large market, we see that there was a 5% increase in both 2017 and 2016. Looking at the illness burden, we see that the illness burden have worsened from 2015 to 2016, which we want to discuss a little bit more on the slide. Looking at the illness burden, we see that illness burden have worsened across all markets, ranging from about 0.28 in 2015 to about 0.35 in 2017. Most of this worsening is contributed by the large food market. In 2015, it was about 0.31, and goes to 0.36 in 2017. However, the individual markets have contributed just as high as the large food market in 2017, which had a score of about 0.35. The individual markets have shown most of the variation compared to other markets, as healthy individuals have exited this market, leaving behind the sicker population. Looking at a 6% increase in spending in 2017, see that increases in prescription drug and professional services spending were the main contributors to the 6%. Prescription drug spending increased by about 14%, which was driven by an 8% increase in utilization and about a 5% increase in unit cost. Professional services, which had a little bit lower increased by about 8%, which was driven by 5% in utilization and about a 3% in unit cost. Looking at a little bit deeper at the prescription drug spending, where we look here at generic versus brand, we see that the brand name drugs had contributed more to the 14% increase in spending, as the brand name had higher level of PFM spending, ranging from about $76 in 2015 up to about $100 in 2017. Also, the increase in PFM spending in the brand name drug was about 14% in 2017, as compared to only a 4% increase for generics in the same year. Looking a little bit deeper also in the utilization of generic versus brand, we see there's no surprise that the increased utilization was influenced more by generic drugs. As you see that the scripts per thousand is much higher than what we see in brand name drugs. There was a 7% increase in utilization in 2017 for generics, and down from a 10% increase a year ago. However, we see that brand name drugs had showed decline, which declined about 1% in 2017, and also a 2% in 2016. Looking at the unit cost perspective for prescription drugs, we see that prescription drug cost per script was largely influenced by increases in drug costs for branded drugs. We see that the level of unit cost or cost per script ranged from the low 400 or 424 to about just under $600 at $578 in 2017.
Yeah, a quick question on when you talk about unit cost in drugs. Could you? That's probably a little bit hard to unpack. If you haven't been exposed to it, what do we mean by unit cost?
Unit cost means the cost per script.
Do we think with those scripts we standardize? So a lot of people get maintenance drugs that are 90 days. Does one of those count for one? Or
and so it works like
For a 30-day, it's going to be one script. 30 days, it's going to be one script. But 90 days, it's going to be about 3 scripts. So the cost script for prime interest increased by about 16% in 2017. We see that the unit cost for generics has been somewhat flat, as averaging about $27 per script. Looking at other service categories spending across all markets, the hospital inpatient rate had grown faster in 2017, which was 4% compared to about negative 6%, which is not shown on this exhibit. The 4% was primarily driven by a 6% in utilization, and to a lesser extent about a 1% in the cost per day here. The lateral imaging is the only service category that showed a decline in spending at 4% in 2017, which was largely driven by a 6% in unit cost, offset by a 2% in utilization. This 6% in unit cost, more work needs to be done to see what role the intensity or mix of services play with this 6% in unit cost. Lastly, we want to see how Maryland compare nationally for per capita spending. The first exhibit alone showed per capita spending in Maryland from the NCDB versus nationally, the national health expenditure. So we see that Maryland is per capita spending is about 6.5% lower nationally and the national results. However, the growth in per capita spending in Maryland is similar to what we see nationally, which nationally we see about a 4.6% growth in per capita spending versus about a 4.4% in Maryland. Looking at the exhibit below, this is a slightly different benchmark where we compare what the healthcare costs. The utilization report is saying what Maryland's per capita cost is. So we see that what's in the MCV and what's in Maryland, what the healthcare cost institutes have said, what the per capita cost is in Maryland, it seems to be very, very, very close, and which is a good testimony as to our reporting on the data in the MCV. However, I must caution you that the data that is used in the Health Costs Institute only pertains to group business, meaning that it's only for employer-sponsored insurance. So therefore, the individual market is not included in this data. Also, CareFirst, large payer is not participate in the survey provided by the Health Care Costs Institute. That's all I have.
Can you bring up that slide again and show the burden of disease? So it seems to be going up in all groups. The illness burden across all market segments worsened from 2015 to 2017. Any ideas as to why? It should be going down, right?
Well, I think it's influenced by the individual market, because as members, as healthy members leave that market, they leave behind sicker population, which influence the risk score.
So that explains the individual market. How does it explain the large employer and small employer market? Still the same thing.
So does the Obamacare mandate have anything to do with it? Basically, the sicker population is going to jump in more into the market and maybe get an individual plan or small employers now are having to offer insurance because there's penalties if they don't. So does that have any impact on this at all? And then will we see a decline because 2019 there's no longer a mandate?
With no mandate means that people would
not have insurance.
would not have insurance. So they probably would come off insurance and leave behind people who might need their care as far as using their benefits concerned.
So these are only insured populations, right? Okay, so what I'm saying is if they're 19, if they're off, then the sicker folks may not even be in the state and we may see a decline.
No, I'll actually do it that way. The healthy people will opt out.
Well, yeah.
Sicker people, because sicker people aren't in because of the mandate, they're in because of the insurance. Healthy people are in because of the
I'm saying
mandate.
that the sicker population, though, probably won't, may not even get insurance if they're under Medicaid, or they just won't be insured. A lot of them aren't insured.
Anything's possible, but you think that if the mandate is what's driving people to get insurance, then it's going to not drive sick people to get insurance, it's going to drive healthy people to get insurance. Sick people are going to get insurance because they can.
Right. I think what I'm seeing is
You increase adverse selection.
in the smaller market, though, for the small employers,
Yeah.
that they've covered more employees. I mean, they've basically made their employees get in. So
Well,
there's not an option where they can get out. That should reduce their burden.
right, because they're
healthy.
they're adding healthy
people to have insurance. The question is whether or not that's going to skew any of this data somehow.
So in the small employer market, there is no requirement that an employer offers. That's only in the large group market. There's a tax credit if you do.
Right.
Others to that effect, it's like there's not large employers have a requirement.
Yeah, but I think I've seen just from businesses I work with, that a lot of them have put on health insurance. They've done it just as a, there's been certainly more advancement in that over the years. Whether or not that continues or not, I don't know, but they seem to.
But they're not in because of the mandate.
Yeah,
So
and
taking the mandate away won't do it.
I'm just curious to see whether or not that had any.
What may have something to do with maybe older, sicker people are working for longer now because of financial reasons, so that may contribute. But I don't think that they have to be sure.
As far as taking away the mandate is concerned, that will only affect the fourth quarter of 2017. So I don't know how because that is when the Trump administration had taken away that mandate. I think it was
So it's still in effect in 18.
Because
we don't have to 18 yet.
Yeah, I'm just saying, no, 18 is still in effect.
happen in the future. Ben, you have questions?
So, yeah, I think it's also, we don't see the numbers here, but there was a bit of a deterioration in enrollment in the individual market in 2017 as a result of uncertainty on what the federal government is doing. I think Ken's point is that uncertainty probably would have been stronger in a healthy population who, premiums were increasing rapidly from 2016, 2017. They also increased again in 2018. We can't see that. Interestingly, in 2019, data not available, premiums stabilized, actually fell because of the state's reinsurance pool, which Brent talked about in terms of the benefits, but we actually saw a small bump up in 2019 in the individual market. What's harder to explain is a small employer market, which is we do see the small employer market actually declining, and one could surmise that some small employers are opting not to insure because they can go into the individual market. But there's such a disequilibrium on premiums. If you're in the small employer market today in Maryland, you're going to be able to get a much better premium, likely yourself, and unless your employees are subsidized, they'll do as well as. So we need to look into that a little bit. My feeling about large employers might be a little bit of noise. Recall that we're now getting in the self-insured employers, which are largely those almost exclusively government employees, which might be tends to be older, and that bump up in large employers might simply mean that we're now seeing the effects of large government employees, which tend to have a bit higher older workforce. So I can't explain small employer. I think we can explain individual and large employer as variation, really underlying enrollment, or actually what we would call the number of covered lives we have.
And also, and the individual markets are decreased by about 17% in 2015. So that might be two things: demand and yes, but also because of the turn in the economy, people maybe find jobs in the employer market. So they probably will be in a small group or the large group. They probably had they are probably a sicker people as well, which would actually influence that the score in both the large group and small. That's only a thought.
Different directions. Yeah. Other questions for Ken? Thank you very much, Ken.
Just one other note. Certainly, Martha, with small employers, might care about this. In the 2019 session of the legislature directed the Maryland Health Benefit Exchange to launch to apply for another federal government waiver, 1332 waiver, to establish a modified small group program to the exchange that would allow for more generous subsidies for small employers with low wage workers. The primary benefit is that the subsidies would not be paid via tax credits on the back end, but would be direct payments. So that's more attractive, obviously, for everyone, but particularly for a small employer who's watching payroll very carefully.
Thank you. All right. Nikki Majewski, Division Chief, Health Information Technology, will provide an overview of key findings from the annual Health Information Technology Assessment, Maryland Acute Care Hospitals Report. The report assesses health IT adoption and cybersecurity measures implemented by hospitals. The information is intended to inform stakeholders about hospital health IT accomplishments and foster conversation focused on enhancing its use to transform care delivery. Since 2008, MHCC has annually assessed hospital health IT adoption. Ms. Majewski, please proceed.
Good afternoon, Commissioners. My presentation today will highlight on some of the findings from our assessment. The full report, along with these slides, were included in your meeting materials. Just a few notes about the assessment. First, it has evolved over the last several years from assessing hospital health IT adoption to now including some information on hospitals' perception about value of health IT post-high tech. That is the Health Information Technology for Economic and Clinical Health Act, which was a key piece of federal legislation that spurred promotion and adoption of EHR. All acute care hospitals do participate in our assessment, and we engage hospital CIOs in the survey design, and then in reviewing the data and presenting that data in a final report. This report helps spur conversations among stakeholders, provide guidance to hospitals, how they compare to their peers and industry at large. This year, the report has a new look. The assessment findings are presenting using infographic dashboards. Some findings are clustered by health systems and community-based hospitals to provide some more perspective about the fusion of health IT in the state. So here are some highlights. EHR adoption is nearly universal across the nation at 96%. Maryland has been at 100% since 2015. Maryland has traditionally led in health IT adoption, and this includes telehealth capabilities, which surpass hospitals in the nation by about 30%. And hospitals are using a variety of methods to send and receive health information, including regional HIEs like CRISP, the state-designated HIE, in which all hospitals participate, which is about increases in case nationwide up twofold. And then regarding cybersecurity, ensuring adequate defense starts with a risk assessment, and there is conformity among hospitals in terms of incorporating certain key components into their risk assessment. This includes the network, education and training, and of course physical security as well. In comparison, all Maryland hospitals do this in comparison to about 3/4 nationally. So here are some of the discussion topics in the report, and I'll share with you some notable findings. A number of hospitals whose population health strategies are rooted in data analysis and exchange report interest in more non-traditional types of data, such as patient medication history. Over 90% of hospitals said this would be of value. And then socioeconomic information, about 3/4. This was actually ranked a little higher among community-based hospitals compared to hospitals. EHR is continuing to revolutionize the healthcare industry. Hospitals view them favorably in supporting communication, patient safety, and in managing utilization. However, there are some mixed reviews about their impact as it relates to physician satisfaction and lowering costs, which is consistent with many national studies. Regarding health information exchange, hospitals view HIE highly for improving care coordination, but are more modest in their views, about 50% about HIE's value in increasing awareness of primary care services. Hospitals report satisfaction with CRISP, particularly in the emergency department. Telehealth continues to build momentum with its growing evidence of how it can support hospitals in managing supporting multiple clinical and business objectives. The majority of hospitals, 77%, are taking an enterprise-wide approach in implementing and managing telehealth to support a broader value-based care strategy. And lastly, cybersecurity remains a strategic issue for hospitals as they continue to build their defenses to keep pace with new and evolving threats. While there is uniformity with including certain components in the risk assessment, as I had mentioned previously, there's less consistency with including medical devices. About 52% of hospitals in Maryland do, which is above the national average by about 20%. This concludes my presentation. As for next steps, we're preparing to release this report and then working with hospitals to finalize next year's survey, which will be distributed later this summer.
Questions? I have one question. So on the cybersecurity issue, do you sense of the frequency of ransomware attacks? How are we doing? I know a couple of years ago we had a couple of high-profile ones in Maryland. How are we doing now? Are we convinced they're all reported when they happen?
So OCR did issue some new guidance a few years back, and a lot of those do fall under the category of a breach. We are going to be doing probably the presentation in a couple months. We're currently looking at the data reported on the OCR portal for these breaches affecting 500 or more, and taking a closer look. But there hasn't been any huge ransomware attacks among the hospitals as far as we're concerned.
Yeah, looking at them.
Yeah, I did.
About that, yeah. So I understand that if there are breaches that involve police records, that those have to be reported. But I would imagine there could be ransomware attacks where there's no breach that occurred yet, right?
Well, so they have to prove beyond a reasonable doubt that if they got into their network that they didn't access the PHI, and that's where the OCR guidance comes into hand, because a lot of people were saying this wasn't a breach, and in the past couple of years, more of those types of attacks have been reported as a breach because once that access into a network.
As soon as they're in the network, you just assume they've got the PHI, even though you could potentially track whether they really did access the PHI or not.
Right. You're correct. I think how it works is if you can segregate out parts of the system you know that they were in, you can say, okay, there's nothing there. But if you can't do that, you know,
right.
And that's not
Which, right. It may not be, but I guess what I'm concerned about is not so much the access to the PHI, but the threat to the ongoing operation that the ransomware attack represents, right? Because obviously the threat to the PHI is something that's worried about at the federal level, it's worried about at a regulatory level pretty substantially. But the threat to the operation of the institution, which represents a real threat to people who walk into that emergency room with a critical condition or sitting in a critical care unit, that's substantial. If the hospital gets paralyzed because of a ransomware attack, we're not hearing about it because there was no breach of PHI that occurred in the process. That makes me worry.
Yeah, so I think it's fair to say that whether it's healthcare or the financial industry, there are lots of attacks to these servers every day. Most of them are called by malware software. There's the vendors come out with patchwork for repairing and boosting the security protections within these solutions. And occasionally they just get through the net. But I think to your point about our hospitals doing a good job, I think it's more than fair to say that hospitals are doing a really good job in terms of their health IT, looking at their solutions, making sure that they have robust protections in place, looking at risk assessments, having solid cybersecurity plans in place, and ultimately being able to avoid what we see happening in some of the local municipalities around the state. They're doing a lot of the job. Quite a lot.
That's certainly the sense that I'm getting at this point, but I just wanted to confirm that's what you're saying.
Yes, we've also found in their incident planning and response handling, they're starting to do more mock exercises to sort of figure out what they would do in terms of operations if there was an event and they had to default back to paper and other.
And just for your information, late this summer, early fall, we were working with the stakeholders getting the Maryland Hospital Association and our neighbors next door at the Health Services Health Review Commission to actually convene a cybersecurity symposium of hospital leaders and nursing home representatives to do some mock exercises and a bit more hands-on training on cybersecurity.
Part of that includes sort of what we've taken the commercial world with the Internet of Things. I mean, Wi-Fi enabled devices, but we're not talking about breaches for PHI, but somebody messing with the heart monitors or.
Well, medical devices is a big concern, but in Maryland we're doing pretty good. You want to sign up with me? It's important to see. So you see in Maryland we're at 52%, and nationally it's at 34%. You might say, well, it's 54. We're 52 where we hang our hat. We would say no, but that is responsiveness to this industry in terms of cybersecurity attacks related to devices. It's a slow but evolving crawl. So doing much better. More work is needed, and I think the hospitals will tell you that.
So I guess I didn't absorb fully what the percent mean there.
Don't you want to tell about how does that percent?
Sure. So with this particular slide, this is actual hospitals that have incorporated these components into their security risk assessment with available national data. On some of the other slides here for Health Information Exchange, this is based on their views, their perceptions that they reported back on their perceived value of these things.
But coming back to the cybersecurity, I think the commissioner started.
That 52% means 52% of the hospitals are including those devices in their assessment.
Correct. 48% are not. Very correct.
Versus 66% nationally. Right?
Yeah, so it's much better. There's lots of room to do better, and we're seeing that progression. But I think what also is notable on this is the top part, where look at what Maryland on these three leading categories as it relates to cyber risk assessment on network, security awareness, and physical security. Maryland is at 100%, where nationally there's still a fair bit of risk.
Thank you. Ben, would you like to share the upcoming activities for the July public meeting?
Sure. We are maybe at a record time today, so
Let's not prove that.
so for July, we're likely to add some items to this, but we have probably 3 CON actions that are planned. We will also have ask the commission to approve the state health information Information Exchange Designation Agreement. This is an agreement that we have historically had with CRISP. We intend to renew that agreement. And that agreement defines the relationship CRISP has with users of the Health Information Exchange, as well as state agencies that take advantage of it. I would anticipate that we'd ask David to spend about 50 or 20 minutes going through that agreement with you. We'll make it available as soon as it's finalized rather than waiting to the week before. We're hoping to finish this agreement up in the next week and a half or so. There are a few details to be tied up. The agreement is important because it's the basis for some state agencies using CRIS services on a non-competitive basis. We're hardening that and adding more clarity on how that would work going forward. And each year, each of the renewals, we've done a better job, I think, of defining, providing a framework for the Health Information Exchange to flourish in the state of Maryland, but also to operate in defined corridors so that both the users of that technology, as well as private companies that may view themselves as competitors, were it not for a designation, feel as though they have opportunities to operate. So we've spent about 2 months working with Chris on the agreement, made quite a few changes, and we'll look forward to bringing that to you ahead of time. We'll also be presenting the report on the work group on non-controlled substances. This was as a result of outgrowth of legislation that didn't pass 2 years ago. We worked with a work group to look at how non-controlled substance information could be made available for care management and other clinical uses in Maryland. You might say, well, when I look at my EHR, that's all there, but the reality is we don't have interoperability. So oftentimes, if I go to, if I'm typically treated at MedStar but happen to visit OMS, the ability to access that information is quite limited. This would be a vehicle through which the clinicians would be able to access at least medication histories through an independent repository outside of interoperable HIEs. It's going to be important. I think there's lots of interest in this, given the different types of care models we're going to go forward with. We will likely, as I said, add several additional items, push the staff to get them to the July meeting because we don't meet in August. So there's a 2-month hiatus. So to the extent possible, we can get things to the July meeting. We will.
Chair, could I just ask Ben, having sat here for two sessions, I had the opportunity to be a guest for one. The staff presents some incredibly well done work, a lot of detail. And we sit here, we listen to it, and say thank you. And is this all required by law, or and I assume all these reports they go on the web or something? I guess what are we doing with all this? Not the CON part, but the updates on, just like we've had 2 or 3 really incredible.
What's the genesis of each of the reports?
Well, and also, what are we doing? I mean, is it just our role to listen and to document it, and that's a law or requirement, or did this body ask for all this? I'm just trying to understand what we're doing here with the law. And if there's not an answer, that's fine.
Well, go ahead.
So,
real quick, I don't want to be called for to extend.
We're doing so well.
Well, so everything we've reported on today, with the exception of this, the advisory council for the MDPCP program, we had an action to recommend, you voted, we had another member added. That is not required by law. The report on vending is required under our statute. What do we do with that? The information is of course published on the web, but that information is also shared with the Health Benefit Exchange. It's provided to insurers and some other stakeholders, particularly insurance brokers. The real future of this report, I think, is in some of the collaborations we have with the Health Insurance Exchange, and we begin, now that they're a little bit more stable, we're talking about how, not this report per se, but information can be gathered to report on behavior in insurance markets, of which on the individual side they have the prime responsibility. On the report that David Nikki presented, that represents our broad authority to foster health information exchange in the state. I think it's actually a pretty popular report in the industry. The report itself is not required as far as my flashing through the statute. That report is not required, but it's broadly covered under the requirements in the statute that we should promote use of information exchange and highlight both successes and challenges of the industry. So ideas you have are always most welcome. Additional information in an individual setting or with a couple commissioners is also certainly have something happy to be generated. The commission, generally tries to tailor what we're required under statute in terms of reporting to what our assessment is of the needs today. So if I hearken back a decade to the expenditure report, it was about a half an inch thick. And what we've discovered is that those types of lengthy reports oftentimes are not read, and we have scaled things back considerably over the last decade. Go ahead.
I was going to say, each of these things relates to our mandates. And one of the mandates, for example, is to promote the use of information technology in healthcare. Our ability to promote that use and to understand perhaps what additional legislative changes may be necessary in the future to make recommendations to the administration and the legislature in that regard is dependent on our understanding of the data and the landscape. So that annual report to us as commissioners helps us formulate those thoughts and recommendations, and it helps staff also organize those thoughts and present them back to us in terms of further recommendations. Each report's a little bit different, though, in terms of its genesis, in terms of why we do it, and in terms of what's expected of us in listening to the report. And I think you bring up a good point that perhaps at the start of each presentation for maybe one slide, just a bit of background as to the genesis of the report, why we're doing it, and what's expected of us as commissioners in listening to the report.
I should say, as a commissioner, I feel free to ask if I don't think it's being promoted enough. What are we doing with this? Should we be doing more? Those are, at least in my view, questions that I would ask if I saw a good report and I was concerned that it wasn't getting out into the world.
Item 9 on our agenda is adjournment. I will accept the motion to adjourn, albeit early. And hearing no